Thank you, Dr. Naz ma'am, for the wonderful oration that you enlightened for all of us. Thank you, Dr. Ramesh sir, Dr. Chandrasekhar sir, and Dr. Arvind sir for chairing the session. Our next session will be Dr. B. Balakrishna Rao Symposium. I would like to call Dr. Siddesh sir, Dr. Lakshman K sir, Dr. Ramesh MK sir as panelists. Along with that, I would like to call Dr. Ramkrishna HK sir as convener.
Hello. Am I audible, sir?
Yes, and we can see your slides as well, Ram Krishna. Yeah.
Yeah. Thank you. Oh,
Make it full screen, please.
Yeah. Good evening, everyone. This oration, this symposium is named after this great man, Professor Dr. Bal Krishna Rao. I thank kscasicon and the executive committee for choosing me as the moderator for this symposium or panel discussion. We wanted to have more of discussion rather than a symposium. So I welcome the panelists today, Dr. Siddesh, Dr. Lakshman, and Dr. M.K. Ramesh. So to talk a few words about the person on whose name this symposium is named, Professor Dr. Bal Krishna Rao. He did his PhD honors in chemistry in 1928 and did MBBS from Bombay in the year 1933, and then went on to UK for doing his MRCS and FRCS. He was there in Mysore for a brief period between 1945 and 47 as professor and head of the Department of Surgery at the Mysore Medical College, and then he went to Gwalior, where again he was head HOD of surgery. Then he became the dean of the same medical college. Later, he joined All India Institute of Medical Sciences, New Delhi, and he was, after retirement also, he served there as Professor Emeritus. He was a great researcher. He has published more than 75 papers in various national and international journals and contributed to several chapters in surgical textbooks. He was the honorary surgeon to the President of India, Gyani Jail Singh. Later, he was awarded one of the best awards, that is Padma Shri Award. He is a Padma Shri awardee also. So, come back to the topic of the panel discussion. This is the often heard question: are we surgeons losing the domain of endoscopy? The other question is whether this endoscopy is an opportunity for a general surgeon or is it a challenge to do endoscopy. And some of the surgeons, they are still doubtful, can a surgeon do endoscopy or is it a physician's domain? To address these questions, this topic was selected, and I thank Dr. Lakshman for giving me this topic for discussion. When this topic was allotted to me originally, I wanted to have some original data of my own so that I can talk authoritatively what are the problems faced by general surgeons. And I created a Google form. This is the link for the Google form. And with that, I sent it across to various surgeons, WhatsApp group, Facebook group, and all. And when I got the data and analyzed, I thought I can write a good paper out of it. And I did it. It was accepted in Indian Journal of Surgery, and it is published recently in December 2021. This is the article which was published. Because we are discussing this from general surgeons' perspective, I wanted all the panelists to be general surgeons only. So purposely, I have not included any of the gastroenterologists or physician in this discussion. So regarding the panelist, Dr. Siddesh needs no introduction to our members, being the president of ASI, and we are proud a man from Karnataka has occupied this highest chair. Formerly, he was professor and head of the surgery Department of Surgery at JSS Medical College. Dr. Lakshman, again, every one of us knows his keen interest in research. He's a very good academician, very good teacher. Formerly, he was associate editor of our journal, Indian Journal of Surgery, and he's a trustee also for bone marrow registry. Dr. M.K. Ramesh also, he's not new. He was the professor and head of Department of Surgery at Bangalore Medical College. Later, he became member of NMC, National Medical Council. Presently, just a couple of days back, he took charge as Vice Chancellor of Rajiv Gandhi University of Health Sciences, and that's me. When this topic was allotted, our chairman, Dr. Arvind Patel, wanted me to write some guidelines for surgeons who want to undertake endoscopy later. So I request all of you to write your inputs in the chat box so that we can discuss, and later we can convert this into a good guideline paper and submit it to authorities, so that will help for the next generation of surgeons who want to undertake endoscopy. So I will come back to this question. Should a general surgeon do endoscopy? Sir, Dr. Sijesh, sir, what do you think? Should a surgeon do endoscopy or not?
Yeah, well, Ramakrishna, you're asking me. Definitely, surgeons should be doing endoscopy. That is one undoubted answer I can give at this stage. You want the elaboration, we'll do it. Yeah.
That will take up a little later, sir. Lakshman, sir, what do you think?
Absolutely. I think it's a must for a surgeon.
Yes, sir. Ramesh, sir?
A surgeon should know endoscopy as well as scanning also.
Yeah. So this, I want to tell you a little bit about my survey, because in the next few minutes, I will be referring to the survey results quite often. This survey was responded by 389 surgeons, and the questions were not made compulsory so that they can give their unbiased opinion. So some of the surgeons haven't answered some of the questions. The total responses may be less than 389 for some of these questions. So this survey respondents, about a little more than half of them were from the private, and about 40% were from the medical college. Those are the medical college faculty, and a few postgraduate students also responded. As expected, response from the rural area was poor. About 16% were from the rural area. When this question was asked in the survey, more than 96% of the surgeons, they felt surgeons should do endoscopy. Dr. Lakshman sir, what is the percentage of surgeons who are practicing now? They are doing endoscopy right now.
I can't quote a particular figure, but I think it's a small percentage, relatively small percentage. Definitely compared to certain Western countries, very few surgeons in this country do endoscopy.
Dr. Siddhesh sir, any idea on this?
No, I would agree. See, actually the numbers are going down. If you compare, when I started practice, there were quite a few surgeons who were at least in the area where I'm practicing, Mysore, around, a lot of surgeons used to do. Now the number of surgeons practicing endoscopy in the mainstay of practice has come down actually.
Yes, sir. So in this survey, about 58% of the respondents said they are doing endoscopy, but this may not be really representative percentage, because those who are not doing endoscopy, they might not have responded, and that may be a very big chunk. So this may be false picture, false percentage what we are getting. What is more interesting is those who said they are not doing, if I ask whether they have plans to do it in future or they are interested to do it in future, almost 90% of them said they are interested. That means majority of the surgeons, they want to do, but they are unable to do for various reasons. Now the next question is, if surgeon, we have agreed that surgeons should do endoscopy. If they are doing endoscopy, is it only diagnostic, or should they do both diagnostic as well as therapeutic endoscopy? Dr. Ramesh sir, what do you feel about this?
I feel all surgeons should be adept in doing diagnostic endoscopy, and a therapeutic, it depends upon the interest of the surgeon. It's good if he learns it, but diagnostic, he should be well aware of it. All should learn diagnostic endoscopy.
I think Dr. Siddhesh was doing both the procedures. Let's see what he says. What's your opinion, sir?
No, I think Dr. Ramesh put it very correctly. Diagnostic endoscopy, I think it should become a part and parcel of every surgeon in their practice. But those who have interest, they can pick up therapeutic endoscopy, because therapeutic endoscopy also has its own complications if you are not trained in doing them. And the complication rates go up in the hands of not so well trained endoscopists. But there are certain therapeutic procedures which are very easy to pick up, especially for surgeons, and they are the ones which can be easily practiced, and they are part of this. When you start doing diagnostic, they become part of it.
Dr. Lakshman, anything to add, sir?
Yeah, I think as my panelists said, my fellow panelists, diagnosis is a must, but I would look at therapeutic at two levels, particularly if you look at the endoscopic therapeutic scenario in the last 10 years or last 8 years. You have certain simple things like polypectomy. I know that in your survey, you actually called it a major procedure, but I would put it under a polypectomy or a sclerotherapy or a dilatation as a fairly basic therapeutic procedure which you can do. And nowadays, of course, as we all know, the submucosal resections and the POEMs have come into the picture, and they perhaps need really specialized training as well as very sophisticated equipment. And so, in my view, definitely diagnostic and what I call the basic therapeutic procedures to be done by the surgeons would be an advantage.
Yeah, then let's see what our survey results says. So here again, majority of the survey respondents, they felt the surgeons should be doing both diagnostic as well as therapeutic endoscopy. Sir, if I'm missing anything in the chart box, please remind me because I'm seeing the.
I'll keep an eye on it. I'm doing it. I'll keep an eye on it. Yeah.
Yes, sir. Because I am going for full screen. I'm unable to see the charts.
I'll look at it. Yeah.
Okay, sir. So that means the majority of the survey respondents, they feel that it should be the surgeon should be doing both diagnostic as well as therapeutic endoscopy. Only thing, they should be properly trained. So if you think they can do both types of procedures, what are the procedures a surgeon can do? I think Dr. Lakshman was doing therapeutic endoscopy before. What are the procedures you are doing, sir?
I do upper and lower GI. Even though I was trained in ERCP, I never took it up here because I had no access to the equipment at that stage. Apart from the diagnostic, I do things like sclerotherapy, dilatation, banding, and polypectomies.
Dr. Siddesh, sir, what you are doing and are doing now?
I continue to do almost what I started doing probably at the peak of my career. Of course, ERCP I started doing in 90s. 94 is when I started doing endoscopy, ERCP full-fledged. Of course, from 86 onwards, I have been doing all procedures, including sclerotherapy, foreign body retrieval, polypectomies, colonoscopies, endoscopic varicose band ligation. Of course, we started late because that became a procedure later on. Yeah. So ERCP 94, but tunnel surgery, I got trained again later, but I practice ESD on occasions, but OM, I am not practicing. Again, because the numbers are not so big, the cost of investment, for as Lakshman put it, we need additional gadgets for it. So, and also require little more dedicated time you need to spend with it, and we need the trained assistants as well. So I'm not doing POEM. Rest all more procedures therapeutic I'm doing even now.
Dr. Ramesh, sir, you were in the medical college. What are you doing these therapeutic procedures there, sir?
No, actually mainly diagnostics for them there in the institution. Most of the medical colleges actually, diagnostics is very common. And in the gastroenterology department, there they do the therapeutic ones.
Yeah, that's the problem. So the same question was asked in the survey. You can see many of them, almost all of them were doing upper GI endoscopy. Compared to that, less number of surgeons were doing colonoscopy. And what is really surprising or encouraging, about 31, they said they are also doing ERCP, like Dr. Siddesh, and the other minor procedures and little major procedures also were done by our respondents. So now with this discussion, I think the verdict is clear. The surgeon should be doing endoscopy, both diagnostic as well as therapeutic. Depending on their level of training and experience, they can do this. Having said, this should be a surgeon should be doing. When should they get trained? Should it be a part of postgraduate training, or should they learn it after completing MS? What do you think, Dr. Ramesh sir? You are in the medical college.
So I feel it should be a part of postgraduate training.
And Dr. Siddesh sir, you were also in the medical college previously. Were you training your students in this endoscopy?
Very good question, Ram Krishna. All postgraduate students who are trained by me, whom I was the first guide. If you ask, they all became proficient in doing diagnostic upper GI and colonoscopy, to say at least they would be adept to do a flexible sigmoidoscopy. Well, if they had put in a little more effort, they can pick up doing a full-length colonoscopy also as well. Whereas when it comes to those students who came on rotation for a period of 3 months with me, they were all again trained. By the end of the 3 months, they could easily perform at least diagnostic upper GI endoscopy.
Lakshman sir, you were also training some DNB postgraduate students. Do you give training in this endoscopy for them?
Yeah, we always offered it, but for some strange reason, many of my DNB students did not turn up for the training. But those who did turn up and showed interest, we certainly gave them training.
Yes, sir. So the same question when asked in the survey, great majority, about 363 of them, they said it should be a part of postgraduate training. But the question is, when we agree that we should train our postgraduate students in the medical college, whether our medical colleges are really teaching endoscopy for our postgraduate students. This is the question I think already answered. Let's see what survey says. There were 147 responses in total, means that these are from the medical college faculty. So 147 medical college faculty were there in the responses. About 55 of them said they are teaching endoscopic procedures, and another 42% they said they are not teaching. This is the problem. And if they are teaching, what procedures they are teaching? Majority, almost all, they are teaching upper GI, and 84 were teaching only upper GI endoscopy. Some of the teachers were teaching on the training on the colonoscopy and a few minor major procedures. Surprising again to see about 3 of them, they were teaching ERCP also. So why our teachers are not training our students? What are the hurdles they are facing while training their postgraduate students? Dr. Ramesh sir, your opinion on this?
So basically, what I see is most of the teachers themselves are not trained in this. I'm not talking about the youngsters, present day teachers.
Yes,
yes, most of them, they are not trained. And we don't have an ecosystem. But all medical surgical departments may not have a separate department to teach this endoscopy. They may have to be referred only to the gastroenterology department. So if you create an ecosystem where every surgery department has an endoscopy unit where all students can go and learn, it can be made a part of the surgical training.
Dr. Lakshman sir?
I think the will to train somebody must exist first. And as Professor Ramesh rightly put it, many of the current teachers perhaps are themselves not doing endoscopy, and so they can't bring themselves to teach others. But one of the solutions that I would have is to have a part of the time of an endoscopy unit, which every college, I'm sure, has, every college and hospital, to be used by the surgeons. I say that in the context of the way I trained myself abroad. The same endoscopy unit was used on alternate days by the surgeons and the physicians in the University of Aberdeen, where I trained. And so the same infrastructure can be used by different people, and it need not necessarily be exclusively used by the physician gastroenterologists.
Dr. Siddesh, what problems you were facing when you were teaching your postgraduate students?
Well, see, my situation was different. because I was the first guy to start doing endoscopy in this area. In the medical college, I was the person who took up endoscopy, pushed it, forced the, in fact, I bought the endoscope and kept it in the institute in the beginning on a loaner basis. And later on, I insisted on them to buy the video endoscope. So that being the case, I automatically became the head of the department. Even when the medical gastroenterologist came, I continue to be the department head. That may not be the situation in most of the institutes.
Yes,
The
sir, you
problem
are
is,
fortunate.
in addition, most of the, I can say that even in JSS now the situation has changed after I left. So what Ramesh told is a real fact that many of the surgeons, in fact, most of them are not trained enough to train the postgraduate student. That is one aspect. But more important is, even if the endoscopy system, which is available in most of the medical colleges now, surgeons don't have an access to it. Forget about their interest. They are not there, even if the surgeon is trained. For example, in JSS, I know about 4 surgeons right now. They are quite competent enough to do upper GI as well as colon. They are not been allowed. After I left, they have been told or shown a way that you are not welcome here. So that is what is really a something which, see, I could do it because of my authority, probably because nobody could question, and all that departmental colleagues whom I trained, who became faculty there, they were my juniors, they continued doing it. But those who are later on joined and after I left, those who are, so that has become a different situation. I'm sure this is the same situation elsewhere.
So mainly it is.
Ramakrishna,
Yes,
there
sir.
are no questions, but I'll take a few comments for 1 or 2 minutes from the chat
Yes.
box.
Yes, sir.
Yeah, Nishant makes the point that many centers will not have the infrastructure and the advanced equipment needed for the advanced therapeutic procedures. Dr. Basan Gaud Patil says every surgeon must do both endoscopy and ultrasound. Dr. Hosni says, totally agree, endoscopy training should be made a part of the PG curriculum. And Naveed says, it's not being done because it is not made compulsory by the NMC. And he says, strongly urges that it must be made a part of the curriculum. Thank you.
Yes, sir. So as Dr. Siddesh pointed out, it is the strong hierarchical system in the medical colleges and the endoscopy being taken over by the gastroenterology department. This is interfering with surgeons getting trained or surgeons training their postgraduate students. I think there are also problems of too many PG seats. Now PG seats have increased. There are too many PGs and it is very difficult to train them with the number of cases available there. The number of cases also have come down, and added to this problem, some PGs, as Dr. Lakshman initially pointed out, the PGs are not interested to learn endoscopy at all. Actually, it is a very useful armamentarium. They are not interested. These are the main hurdles they are facing. But the problem is not isolated or special to India. The problems and hurdles are there across the world. According to this article from Australia, they also say the necessary infrastructure, like a dedicated endoscopy suite, it's not available there. They are doing endoscopy in the operation theater, which is not really suitable. And this second point was already mentioned by Dr. Ramesh. The person who can train the residents in endoscopy, they themselves are not trained in the endoscopy. So the proper persons are not available there, and getting enough number of scopes to do with this training and exigencies are difficult. Also, the investment on newer scopes and newer technologies like chromo, narrowband, etc., they are not available. Even in Australia, they are telling the investment is a problem. And this is paper from Canada, which is from the residents' point of view. About 93% of the surgical residents, they had training, but 85% of them did not fulfill the minimum specified number. Means they have specified a minimum number of so many cases of upper GI endoscopy, so many cases of lower GI endoscopy should be done. But this number was not attained by 85% of the students. Having said the problems across the world, what are the guidelines from National Medical Council or universities? We are concerned with Rajiv Gandhi Health University, and our Vice Chancellor is here. I think he is the right person to take up this question. Sir, what are the guidelines from NMC or your university regarding training of postgraduate students in endoscopy?
In the Rajiv Gandhi University guidelines, it's just thusly mentioned that is a part of the curriculum, that endoscopy. It is not been elaborated. And NMC as such hasn't formed the guidelines yet. Old MCRI regulations are there, MCR regulations are there. Indeed, also the idea at that time was just to give an exposure to the endoscopic, not as a part of the training. But the days have changed now. Maybe we may have to change the regulations. In fact, we were in the process of revising the curriculum for surgery in all the subjects. If we have sent it, we hadn't received it. Because the pandemic, and NMC is a new organization, we had a lot of problem with the staff. We had removed a new staff over there. So, in fact, it's in the process. It's in the process. At the end of this thing, if you give a memorandum to me, that I will definitely make it a part of the curriculum. In fact, I had that idea. I would have included even otherwise. In the Rajiv Gandhi University, I'm definitely going to make it a part of the curriculum.
Thank you, sir.
The endoscopy training for postgraduate students will be made mandatory training part.
Yes, sir. This is what we were expecting. That's initially only I told our chairman, Dr. Arvind Patel, wanted some guidelines on this. So with the inputs from the panelists and the whole audience, we will write one guidelines and submit it to you. Sir, please forward it and take necessary steps to make the endoscopy training for PGs a must, so that will help these surgeons to take up endoscopy later. And this is the need, because most of the peripheral areas in the India, like I am from a rural area, here there is no endoscopy. I started one about 25 years back, and still this is the only endoscopy center, and I am concerned only with diagnostic endoscopy. So when it comes to therapeutic endoscopy, again you have to refer. So if trained surgeons come, then the problem of endoscopic services in the periphery will be solved. This is the need of the hour, sir. So what are the procedures included in the curriculum as a part of training? Any ideas, sir, in this?
It's not been defined actually. We will define it in the future.
Yes, sir. This I went through the website of RGHS. It just mentions about 10 procedures should be done by a postgraduate student before completing his degree. That's what it mentions. I think we need more elaborate guidelines and training details regarding this. That we will do in a short course. Even this also probably many of the PGs are not fulfilling, I feel. So, Dr. Siddheshwar, you are doing endoscopy. What do you think? If surgeon is doing endoscopy, there are advantages, or it is same as getting report from a gastroenterologist or physician?
Siddesh, before you come in, with your permission, I'll take some comments from the chat box. Dr. Godi sir says NMC insists that an endoscopy should be available in the surgical OPD. Rajgopal Shanoy feels that disagrees with our view that PGs are not interested. He feels that they are interested, but that they do not get the opportunity. Kalaivani, of course, reiterates that it should be made, endoscopy must be made compulsory in the PG curriculum. There are 2 or 3 other comments to the same effect. And again, Kalavani says non-availability of endoscopes in the surgery department is a hurdle for them to show interest in undertaking endoscopy. Siddesh, please.
Sir, regarding Dr. Rajgopal Shanai's comment, that line I introduced, it is based on the inputs from the survey. Yeah. Some of the medical college staff who responded, they quoted this as a hurdle. That's why I have mentioned that, yeah. Sir. Yeah. Probably in your institute, it may be a little different. This is, I'm talking from the point of view of whole surgeons. So, Dr. Siddesh, sir, what are the advantages?
At the same time, Ram Krishna, that could be an individual opinion of that teacher who has responded. Anyway, that leave it there. I just want to respond to one of the respondents is that on the chat box, Nishant wanted gadgets for therapeutic endoscopy. See, majority of the gadgets which are required to do a basic therapeutic procedures are not very costly. We can start with that. So we don't need chromoendoscopy or narrowband imaging. They really, even if they were available in JSS for the last 10 years where I worked. But to use those gadgets, you need to have a dedicated time. You know, one case of suspected early malignancy, you need to do a very good study using all the three parameters of magnification endoscopy, narrowband imaging, and chromoendoscopy. It takes more than 1 hour for one patient. So we need to, I told I am unable to devote that much of time. It is not that big expertise which is required. You need to follow protocols. We can do it systematically. We are all trained in it. But the problem is we need to also spend time doing it. Like endosono, we almost acquired at the time when I was about to leave, but I told no, because it is not that we cannot afford. I have to put in extra skill learning, but even if I learn, I need to spend that much of extra time with each patient. So that was not in my domain. So that is what we need to think. So that is one part of the discussion. Now coming to what advantages if surgeon is doing endoscopy. I'll tell you, Ramakrishna, if there is a CA rectum reported by a colonoscopy done elsewhere with a histology, with a CT scan, I will do a rectal examination as a surgeon all the time, because nothing replaces rectal examination in the CA rectum. But again, I will do a colonoscopy or a sigmoidoscopy to at least to assess that particular lesion myself. So that gives me a real confidence whether I'll be able to do a comfortably anterior resection, low anterior resection. It is not just the level alone. I'm sure all surgeons will agree. Seeing the lesion myself will give me a bit of a visual conception where I'll be more confident in handling this. Similar thing about carcinoma of the stomach, especially proximal gastric cancers. I would be very comfortable planning my surgery, GE junctional tumors. So these are certain things where I can take a call myself what I am planning for these patients when I do the endoscopy, see the lesions myself. What will be the clearance length I can get, where I can plan my anastomosis. These are the issues which really comes to my mind. So I'm more comfortable seeing these lesions myself. So this is the basic thing. There are various other advantages I can go on naming. And for example, a GERD patient, I have seen plenty of patients like GERD being treated by a medical gastroenterologist conservatively, where if a surgeon does it, probably he will take a decision on an anti-reflux procedure, either laparoscopic or open, depending on his expertise, much earlier, which is deserving, the patient deserves. So there are many other things which I can go on telling. But of course, complications we can definitely be better in managing. All that are minor things. But definitely thing is these things which I mentioned.
Lakshman sir, do you do endoscopy for all the patients before doing surgery? Means those patients who requires endoscopy, will you do yourself, or you are asking your fellow and physician to do it?
Always, I do it myself.
So what are the advantages, sir? Why you do it?
Oh, Siddesh has listed most of them. Yes, your planning can be better. You know, to give some more examples in addition to what Siddesh has said, if you're looking at a gastric neoplasm, for example, when you're planning what kind of a gastric resection you want, you're very keen on the distance between the OG junction and the proximal extent of the neoplasm, particularly on the lesser curve. I do not see a physician gastroenterologist giving me that specific information. So many times if patients are diagnosed by a physician with an endoscopy report and they come to me, I say, please permit me to do an endoscopy. I may even do it free of cost, but I would like to do that to know more about the, the surgical, what I call the surgical aspects of planning the surgery. Siddesh has mentioned it. If you have a little leak from a very small leak from an esophageal resection for anastomosis, you can put a stent across it. I have myself dealt with by injecting glue. When there's a tiny little hole which gave a leak, I injected glue endoscopically and that hole closed. And it's very nice for me to do that. And much more importantly, when it comes to costing, particularly in private practice, it is nice to have the flexibility to do it yourself so that you can help the patient and manage within a particular amount of money that the patient can perhaps spare. And the policies going at a different level. For example, we have some physician gastroenterologists. I send my ERCPs to them, as you know. I don't do them myself. In spite of a very clear cholelithiasis, abnormal LFTs, where I would like an ERCP stenting, perhaps clearance on the CBD, they insist that an MRCP must be done before they even consider an ERCP, which I feel is not reasonable, but I have no choice. If I have to send it to him, we will do the ERCP. And so, or we must find another person who will do it without the ERCP. These are little things where I believe that the surgeons are, at an advantage if they do the endoscopies themselves.
So when this question was asked in the survey, there were so many different answers. See, the Google, it gives one color to one answer. So many colors it has given. It is giving a beautiful wheel of colors. And this is one of the 3 pages I got. So to summarize them, is the surgeons will have better dexterity to handle the scope than their physician counterpart, because we are known to work with our hands. The other thing is it helps in planning the surgery better. This our panelists already have highlighted. Other things what I wanted to mention is it helps in handling complication of a procedure. Means you have done an endoscopic procedure, a complication has occurred. If you have done the endoscopy yourself, you will be able to handle that complication also, or sometimes a complication of a surgery which requires endoscopic treatment. Here also, if surgeon himself is doing endoscopy, it will help. Sir, our panelist, what do you feel, sir? Whether you agree on these points? Yes or no, sir? Dr. Lakshman, sir?
Yes.
Dr. Siddesh?
Yeah, definitely yes. I cannot say no. More so if you're doing therapeutic procedures. I will tell you, Ramakrishna,
Yes.
in addition to the skill and dexterity what we are talking about, we have handled these tissues ourselves. We know what they are made of. Number 2, we know how much when you cut, how much will result in a real cut on the tissue. And especially when you're using a electrosurgical diathermy, you know these electrosurgical units are being used by the surgeons day in and day out. And the advancement in electrosurgery, we understand much better. We know the complications of using them indiscriminately. So we are much more adept in using these gadgets. And we are really gadget savvy. If you ask me frankly, that is the word I would like to use. Surgeons are better gadget savvy. They are more comfortable using the gadgets. So I think that is where we score. Coming to the ERCP, as Lakshman mentioned a real instant, I would like to add, if there is a large stone, there is a recommendation, standard recommendation of multiple ways how we can handle. I will tell you, even in the most sophisticated setup where I worked, tertiary referral, it would require 2 or 3 sittings. To blast a stone, you would do a lithotripsy, sacrifice a basket, use a laser, or many other gadgets. But I will tell you, if I'm a surgeon, I will err. I will take this patient I will just place a stent, take it patient onto the OT on the next day and do a laparoscopic CBD exploration.
Yeah.
See, this is what I have conveyed my message.
Here the discussion is more not on the techniques, but more
no, not technique. I'm telling you, if a surgeon is doing, he will take the decision much earlier.
Correct.
Than attempting
that point is important. Yes, sir.
In the same, Krishna, if I come in the same vein, decision to operate in a GI bleed is much better, much safer, and much earlier when a surgeon is primarily handling the case. Time and again, we have seen people who have bled far too much and for far too long being referred to us, and obviously the surgical results will also be poorer.
So that means it helps in planning the surgery in a better way. Dr. Ramesh, sir, you said you are not doing it, but still you can comment on this point. You agree?
My comment is emphatic yes.
Yes, sir. Thank you, sir.
Krishna, can I take the things from the chat box again?
Yes, sir.
Godi sir makes the point that he has seen during an NMC inspection for the recognition of a college, the inspectors insisting on an endoscopy suite in the surgical OPD. So the NMC is well aware of this. Sopimat has written 2 comments. It may be easier if, with your permission, Ram Krishna, if we ask him to speak for 2 minutes.
Dr. Sopimat, sir, please.
Yeah, please, please go ahead.
Yeah. Thank you for asking me to comment. Actually, I've been a very great proponent of this endoscopy for surgeons, and we have been training surgeons. But my concern is that 2 things. One thing is many surgeons are giving away doing endoscopies in practice. That is because of the politics in practice, I call it as, because there is an interdependent practice it has become. So I think that trend to break, many surgeons should start doing endoscopy. And main second concern is I studied a lot the NMC curriculum in the new curriculum and the old curriculum. I think I've put it in the chart box that in the new curriculum, it is just reduced to 1 sentence that including endoscopic management of CBD stones. Earlier, it was diagnostic and therapeutic, upper J, lower J, everything was there. But that sentence is missing in the new curriculum. So I have returned to all ASI leaders, and Dr. Siddesh is aware, and I have been pursuing this matter so that this is brought back in the NMC curriculum. We have fortunately Professor Ramesh here, who is also our Vice Chancellor and also in NMC. I think, I'm sure that he would take it up because he strongly endorses this fact. And of course, I agree with all the points what you have all expressed in decision making, treating, confidence, dexterity, everything. I agree on that point. So we need to impress upon the youngsters to take it up as a curriculum in future and as a career also. Thank you.
Just clarifying, Sopimat, that Dr. Ramesh said in the beginning that the postgraduate curriculum of the NMC is work in progress. So in the coming months, they would be giving you more details about it. Yeah.
Agree. Yeah.
Ram Krishna, please. Yeah.
Yes, sir. So coming to the data from the survey, what our survey says, the surgeons have got better dexterity than physicians to handle the scope. Majority of the survey respondents, 333, they agree, yes, it is. And some of them are not sure, but the emphatic no was really minority. Only 6 said no. Whether it helps in planning surgery better, again, 354 agreed on this point. And whether it helps in handling of a complication in a better way, again, 354 responded. They said yes. So that means there are definite advantages if surgeons themselves are doing endoscopy. This one last thing I wanted to tell, a surgeon can manage a case conservatively, but a physician cannot manage a case surgically. That is the final nail, I think. That should make you very clear. Surgeon should be doing endoscopy. When there are so many definite advantages and everybody agrees surgeons should do endoscopy, why many surgeons are not doing endoscopy? What are the problems they are facing? What do you feel, sir? I think some of the hurdles have been already mentioned. Anything to add, sir, Lakshman, sir?
Nothing much to add. I think it centers around availability of training, availability of equipment, and to some extent the ecology. When they come into practice, they may want to be in the good books of their physician colleagues, and they may not want to in some way rub them the wrong way. That may be one of the reasons where they don't take it up when they start their practice.
Siddesh, sir, anything to add?
No, I think all these have been covered.
Already
that
covered.
Hesitancy has now become an added factor of late. What Lakshman was mentioning of late, that if you are practicing, especially in an institute where physician is a leading practitioner of that institute, you definitely go backwards. You take your foot backwards. Let me not push myself for endoscopy. So this is what I have seen. And of course, today what has happened, I have been, Ramakrishna, let me tell you, I have been attending all therapeutic endoscopy workshops for the last 20 years, wherever they are held at the national level. And having attended so many, and of course, many of them are organized by the medical gastroenterology associations. So there have been separate discussions which go on for accreditation. The DM degree must be one of the essential criterion to do endoscopic procedures at institute. There is a lobbying going on there. So we need to be aware about this as well when you take up this. So, but they have not been successful. But we don't know, our governments can handle these situations depending on who approaches them. So we need to be aware of this aspect as well.
Yes, Ramesh sir, what do you think? What are the problems? Why surgeons are not?
I think most of the things have already been covered by Dr. Lakshman and Siddesh and others earlier also.
Yeah.
No need, nothing to add.
In this survey also, there were so many suggestions like this, and this is also going for about 3 pages, so many things to summarize them, because most of them, they were repeating the same thing again and again. I have summarized it for you. The lack of exposure and training during their postgraduate studies, this is one of the major reasons why the surgeon, when they come out, they are unable to practice endoscopy. Some of them were afraid of medical legal implications. They think if they do endoscopy and some problem occurs, then the court of law will punish them. And some of the hospital policies, only medical gastroenterologists will be should do endoscopy. This is some of the hospital policies. So again, that is a concern. And some of them were concerned with the adverse relationship with the physician. Dr. Siddesh has already made a mention about that. And in majority hospitals, the gastroenterologists have taken over endoscopy. So surgeons are losing this domain of endoscopy, which I think we should claim again. The other problem, especially in rural area, we always think of the investment. If I invest a few lakhs on this, whether I am going to get back or not. This is also some of the surgeons they have showed. And some surgeons are too busy doing surgeries. They think it's not worth spending time in doing endoscopy. So they will be making more with surgeries only. They're unable to dedicate time for endoscopy. These are the problems they mentioned. I think this is mainly it is the mindset. With proper mindset, all these problems can be tackled and surgeons can take over endoscopy. I think Dr. Lakshman wanted to tell something.
Ishwar Osman he's a principal.
Just before Ishwar, one sec, Ishwar, just taking things from the chat box. Godi sir has an interesting take. He says with so many other things to do, with so many specialty postings, pressure to present papers, thesis work and all that, training PGs to become proficient in endoscopy may not be practical. That's one of his views. Ishwar, please come in.
Yeah, yes, sir. I heard a lot of discussions going from all the people, the expert opinion. Even I do agree, endoscopy should do, surgeons should do an endoscopy. In a medical college, preferably every unit has an endoscopic unit day, the next day of the OPD. Majority of the units were doing the therapeutic endoscopy and diagnostic will be regular, therapeutic endoscopy in some of the units. Then the major shift of general surgeons going away from the endoscopy because attraction towards the laparoscopy, because this is the one branch which is still left the general surgeons, whereas gastroenterology more or less is almost taken up by medical gastroenterologists, unless we have a curriculum or required to complete general surgery courses, then endoscopy is going to be remain. If there are no curriculums are made, probably it is gradually giving away from the surgeons. But every teacher, as Dr. Ramesh has said, should be trained to do endoscopy and then teach their postgraduate students. Whenever we do an endoscopy day, we always take our postgraduates and make sure that they are acquainted with the basic things, especially the final year PGs are allowed to do an endoscopy so that we can still retain the training curriculum among our postgraduate students. As Dr. Saprivat put it, we are already returned to all the various governing bodies regarding the need of the endoscopy for as general surgeons. Then we are going to include a training sessions also for the training and trainers so that we can once again bring the glory of doing an endoscopy for general surgeons. Thank you. Thank you for giving me 2 hours.
There are 2 questions, Ram Krishna, in the chat box. One of them, what is the average cost of setting up an endoscopy unit?
Well, sir, it depends on what all you want to have. I think if it is only diagnostic upper GI endoscopy, it should cost somewhere around 10 to 12 lakhs if it is a video endoscope. If you want to have therapeutic also, then depending on the level of procedures you want to do, it keeps on increasing. And if you are doing ERCP also, I think you should add a COM also and a special OT. It should not be done in a regular OT. Endoscopy theater should be there. Endoscopy suite should be there. So it will add on to those cost, I think. I think Dr. Siddesh has got the experience of establishing his own. He should be able to tell what is the cost involved.
I think you have been fairly near to the accurate. things have been changing off late a bit, but there are at the same time, because of the competition, newer companies have kept in. A diagnostic endoscopy should not cost more than 15 to 20 lakhs, depending on what brand you choose. So of course, ERCP is a different ball game. See, there are 4 components of ERCP. One is the equipment and the gadget. You need to have a CRM, as you mentioned it. But most of the institution, CRM is a shared unit between orthopedicians, neurosurgeons, and vascular surgeons, etc. So you can use it as a part-time, partly belonging to you whenever you have a case. Of course, most importantly, third aspect of it is ERCP requires many gadgets, which are very costly. Each ERCP would require a sphincterotome, guide wire, balloon, a basket, a stent pusher, many other things. So though they are not lasting, actually, so to say each one of them have printed no, second into, that is, you cannot use it for the second
Single
time.
use, single
So
use.
we have, they are all single use, but we do a rewash, do a ETO gas sterilization, and we reuse them. And I think this has become a norm even in America, and even NHS, they have permitted now ETOing of these because the cost effectiveness has been proven. They probably took the cue from India, but we need to take all these precautions even if we are reusing them. So that makes it again costly. So that is what they are, the restrictions.
Yeah, there's another question. What is the medical legal position regarding surgeons doing endoscopy?
I think we will come back to that a little later, sir. One of the slides is there. We'll take up that question later. Right. So that is the next slide. What are the medical legal issues if surgeons does endoscopy? Lakshman sir, do you think this will be an endoscopy medical legal issue?
Certainly not. Certainly not. I think the judiciary in this country is mature enough to know who is trained and who is not trained. And in fact, there are many judgments where you don't even have an official degree, but because you're recognized as a fully trained person, you can prove it by your logbook, for example, or certificates and things like that. So I don't think there is any medical legal vulnerability.
Siddesh sir, what is your opinion?
Yeah, I think I have so far, luckily, I don't know, not faced a medical legal issue for performing an endoscopy and ending up with a complication. Nobody has questioned me, why did you do an endoscopy to me? Probably with me, it was undisputed because I was a leader in this area, in this region and in my institute. But otherwise also, I feel this question comes only with the therapeutic endoscopy. Apogea diagnostic endoscopy is associated as such with less complications. Only thing is you might have missed a lesion, then you may land up with a problem. Otherwise, it should not be an issue. Whereas therapeutic endoscopy, well, as Lakshman put it, you have certain credentials. You can have your records that you have attended so many training programs and you are qualified a basic specialist and you have an access to these equipments and you absorb all the safety protocols. I don't think it should be an issue.
I should add here that there is a concept in the judiciary about affidavits. So it's not necessary that you need to have a degree or a certificate which says that you're good at something. If you get 4 or 5 of your colleagues to give affidavits supporting your expertise in a given area, and that should not be difficult to come by, then you can safely defend yourself.
So even in the survey, majority, about 83% of the survey respondents, they felt there should not be any legal problems. About 13% were not sure either way, and 3% said there is problem. So I think this answer, what our panelist gave, it should alleviate their anxiety about these things. What are the issues, medical legal issues that can come up? Again, we have a big list of them, and important of them to summarize for you. The majority of the surgeons, they think they need a certificate to practice endoscopy, and some they feel only physicians are allowed to do endoscopy, surgeons are not allowed. And the proper certified training courses, this is not forthcoming, so they have not undergone these things, so they are not doing endoscopy. And some of them are not sure if endoscopy is included in the curriculum of the postgraduate training. And when I started, there was no gastroenterologist here. I started doing endoscopy, but mind you, I am doing only diagnostic and a few small minor therapeutic procedures. But if a gastroenterologist come in this place, then should I continue to do endoscopy or should I stop? This is the question they have in their mind. And there are no guidelines, proper guidelines anywhere available, either from the association or from the university. So they are doubtful whether they can do endoscopy or not. And some of them, they fear when complication occurs. Are you an gastroenterologist to do endoscopy? I think as our panelist opined, these are all more myths than fact. With proper credentialing and proving your case, giving evidence, you can solve these problems.
Ram
And
Krishna, Dr.
Yes,
Naz asks a related question. Who should give the affidavit? Should it be a gastroenterologist or a colleague surgeon? I believe any surgeon colleague of yours giving you an affidavit will be as useful as anybody else.
Yes, sir. And the other question, what I felt, if the training is included in the postgraduate curriculum, does it give a legal protection? I think 2 days back, we heard Dr. Harsha was talking. When a particular surgery or particular field of surgery is included in the postgraduate curriculum, and if they can prove that they have undergone this training, that should give protection medico-legally. What do you think, sir? Dr. Ramesh, sir, please opine on this.
Now, once it's included in PG curriculum, automatically it gives legal protection.
Yes.
Where the court cannot ask, when he has been trained officially in that, it doesn't have any right to ask that.
Yes, sir. I think this is one of the solutions to the problem of this one. And the other thing is it really difficult to train surgeons in endoscopy? Because so many medical colleges, they are not training. There may be different reasons, but some of them, they think it is difficult to train surgeons in endoscopy. What do you feel, Dr. Lakshman, sir?
Not at all. I think it is, relative to training people in surgery, be it open or laparoscopic. Endoscopic training, I believe, is easier. I think is easier.
Yeah. Siddesh, sir?
Yeah, it's not difficult. But there is one query which was raised by Dr. Godi, a senior surgeon. He told that the numbers are less for training because number of PGs have gone up. But today, again, MCA has put norms that every institute has a skills lab.
Yes.
I think today all skills labs should have a position of a simulator or a basic gadget where they can simulate endoscopy. So if there is a train, main issue I feel is we need to get the trainers trained. So we do that, and that will give an added motivation for the program where they can train. And then one more suggestion which I wanted to talk yesterday because of the lack of time I couldn't mention is about exchange program. There are centers of excellence where there is a high volume. Like when I was a postgraduate for oncosurgery, we were posted for 1 month in Kidwai. You see, now in JSS, we have an oncosurgeon, so we don't post. But still, I feel if they go to Kidwai for 1 month or even 15 days, they get a wide exposure. Their approach to oncosurgery and principles of clearance, they get a better concept, I think. And then when they come back, they can start understanding them better when they continue in their curriculum. Same way, endoscopy, even if they go for an observation for a week or 10 days, such programs should be encouraged.
Yes,
should
sir.
be part
Even
of our training.
In the survey also, more than 92% of the respondents, they felt it is not too difficult to train a surgeon. See, that is the opinion. Even I can give you one data also. See, in UK, there is a program. And in the website, when I checked, there is a endoscopy training of 30 weeks for non-doctors. The disqualification is if you are a doctor. If you are a doctor, you cannot apply for this program. So when non-doctors can be trained to do endoscopy, it should not be really difficult to train a surgeon with the knowledge of anatomy and clinical experience. It should be quite easy to train surgeons. The other thing, the cost of endoscopy, it already came, that question. And the thing is now, is it worth investing on endoscopes? Please, Dr. Lakshman, sir, what do you feel? Is it worth, will the investment come back?
Difficult question to answer. It depends on where you are, and it depends on where you are and what the volume and the type of your practice is. It has to be an individual decision. But I can tell you for the first 25 years of my 36-year practice, I had my own endoscopes. And then when I found that, the kind of nursing home milieu I was working in, they would not invest on endoscopes. So I used to carry my endoscopes around and do it. But then later on, the last 15, 20 years, I think 15 years, people have started investing. And so I now use the institutional endoscopes.
So you feel it is worth investing on endoscope.
Definitely.
Siddesh sir also definitely say yes, because
No,
already invested.
But Lakshman, we were early birds. Those are the days we invested from the day one. We had patients for endoscopy. We survived on endoscopy even much before we started getting busier with our operative work. That is true with me. On the first month itself, I did around 35 endoscopies. I was something which was revealing for me. But I will tell you that is happening. That happened because we were the first time early birds. So, but today, what I would advise for youngsters is don't expect returns from the endoscopy. See, those days I bought my first upper GI endoscope I viewed for 1,20,000. That was a huge investment for me. I had to beg for a loan because they needed collateral security. I didn't have anything to offer. My father didn't have any other property to offer as a collateral security. I had to go beg banks. Ultimately, one cooperative bank came forward because of some association they give. So I'm telling you, so that 1,20,000 was a big investment those days. But today, even if it is around 8 to 10 lakhs for upper GI, it is relatively an affordable thing. Number one.
Yes,
Number
sir.
two, you cannot expect direct returns like I do today. In a first month 40 endoscopies and get that money, prepay back my EMI. It doesn't happen that way. You pick up one case of malignancy in 2 months, that will pay you. And that malignancy will fetch other patients to you. See, this is how it works. You treat one upper GI and a bleeder, you recognize, treat him conservatively, that patient will get you patients. So your practice builds around you start, and also people around you, general practitioners, start identifying you. You are a GI man. You have an endoscope. So they will start referring you. Your image goes up in the practice. So that's what I recommend.
There are collateral advantages.
Absolutely.
And I think this should be one of the armamentarium. This is, you cannot depend totally on endoscope, but if it is one of the armamentarium, definitely it will add on to your income. Even in the survey, about 85% of the respondents, they agreed it is worth investing, and about 10% they were not sure. 4% said it's not worth because they have probably some bad experience in that. The other thing is the relationship with the physician. Sir, Lakshman sir, you are doing, whether your physicians felt bad, we are doing endoscopy because you have taken over of their practice.
We certainly had people even openly expressing, physician colleagues openly expressing that we should not be doing endoscopies. That was the milieu at that time. But I do believe it has changed now because there are so many centers, so many people coming in. There is a general increase in the volume of work and all that. And so I don't think it's a big point now.
Yes.
I do not think you
absolutely.
Yeah.
Sir, Ramesh sir, what? Yes, sir.
Can I add one word? See, yes, not only the numbers have increased, patient load has increased, the indications have increased. See, earlier, the simple weight loss, anemia, people wouldn't have referred for endoscopy, colonoscopy, stool for occult but positive, colonoscopy, routine bowel change. Today, we know colonoscopy is a must.
Sir,
so
what about
the indications, awareness has gone up.
Your physician, whether they are objecting for you to do it or they were encouraging you?
No, always. See, for us, I told you in the beginning itself, it is an early bird advantage.
Yeah.
Now
your
it
situation
is not
is
so
different.
Yeah, correct.
Ramesh sir, what do you think if a surgeon is doing, whether the physician?
Sir, in my view,
department?
Sir, in my view, it's no longer a factor actually. It all depends upon your interpersonal relationship, and knowledge and skills are nobody's property.
Correct, sir.
If you are competent, you will do it. If you do it well, all will appreciate. That's all.
Absolutely.
Results are more important than
that is talking like a lawmaker.
Mature man.
Sir, Bal Krishna, we have only 5 minutes.
Oh, so sir, we will hurry up a little. the survey, about 2/3 said there is no relationship, means the relationship will not be affected. And coming to the solutions, I think including the endoscopy training in the curriculum and credentialing of the surgeons who have already passed out and they are not already trained. If they are credentialed with this, then they will get some protection. And establishing good number of training centers who can train our surgeons, then these are the need. And if it comes to credentialing, who should do this job, whether the association or the university or any specific centers who get the recognition? Sir, please be specific, and because we are running out of time, quick answers, please. Dr. Ramesh, sir.
Sir, I think here associations also should contribute their might, and if they give the proper input, definitely we will include in the regulations.
Yes, sir. Siddesh, sir.
Yeah, I think
Association,
credentialing
do
can be
something
done
for
at
this?
high volume centers. We can have centers who are running routine training programs, and those certificates will be definitely of value.
Yeah, can ASI do something for this? Being the
Yeah,
president of
definitely.
ASI,
Definitely, we are working on it. We are working on it.
Yes, sir. Lakshman, sir, any suggestions on this?
Nothing beyond what they have said. Yes.
Yes, sir. Thank you. And I think this is the problem of credentialing across the world. I think Dr. Lakshman will be able to explain this better in a few words.
Yeah, I'll run through this because of lack of time, but you can see that there are large numbers of endoscopies that are recommended for credentialing. And even abroad, where they have these strict standards, many people, as Ramakrishna showed, 85% of residents do not meet these numbers. But it is good to have some numbers and maybe be a little liberal about how many they actually do, so that we can start the program off. Next one, please. And the important thing there is that you should have an audit. When it is done, we must know that it is actually done. So some kind of external supervision and auditing of the training program must go on a regular basis. And the Joint Credentialing Committee in the UK has, very interestingly, physicians, surgeons, radiologists, and GPs. And they have shown that it has had a very good impact on the quality of endoscopy service in the UK.
Yes, thank you for those inputs, sir. Can you name some of the good training centers where our surgeons can go, whether they charge anything or how much I have to spend for getting trained in endoscopy? Can you, any of the panelists can mention some of the centers?
Yeah, I mean, I try to look at it, but there is no definite information available. And that is perhaps a job that Siddesh could consider. Maybe have a database of centers with their details and the, their volume of work and things like that, where if we can collate it and give it to the ASI members, it might be of some help.
No, I would chip in here for the young surgeons who are looking up to pick up endoscopy. They cannot go spend that much time to pick up endoscopy. Suppose they need to spend about 2 months. They cannot go to gastroenterology. That 2 months they are off their routine work, which really keeps them bothering about it. So they need to go to a center where they can pick up endoscopy, laparoscopy, open surgical
centers, sir? Do you know any center which imparts training?
There are. No, see, you should look up. There are no center right now I can pick up, but there are certain people who are conducting short courses of 3 days, 4 days, like Roy Patenter at Chennai.
How much do they charge?
I mean, Mumbai. The charges, of course, I think they charge around 25 to 30,000 for a course.
Yeah, I think
that's what normally.
Those who are interested, they have to do some Google search and find out and contact the centers directly. Okay. So, as Dr. Lakshman said, probably ASI will consider having a database of these training centers that will help the young surgeons. And what is the global trend if you look at it? And the problem of credentialing, training, all these things have been discussed, and it is not special to India. There are problems across the globe also. I again asked Dr. Lakshman to explain in a few words these 2 slides.
Yeah, and again, time is up actually, and so I think we'll have to really rush through this. Yes. What is interesting is that across the world, particularly in the UK and Canada, not so much in the United States, surgeons do half the work, endoscopic work. And later in the day, in fact, much later than otherwise, the American College of Surgeons made it mandatory for their residents to learn endoscopy. And so they're actually behind Europe and Canada in terms of surgeons doing endoscopies. Next one, please. Yeah. And even the trainees in Canada, that's where most of the information is available from. They felt that it's a necessary skill. A lot of them were doing it, but they really felt that the training could have been better.
Yes, this is from my friend, Dr. Jayaprakash Patta, who is practicing at Birmingham in UK. He has also taken this survey, so I can claim my survey as international with this single response from there. What he says is the endoscopy services there is shared by gastroenterologists and surgeons. Surgeons are mainly concerned with the diagnostic and a few therapeutic work like polypectomy, EMR, etc. Whereas gastroenterologists will be doing major therapeutic interventions. Now, already I mentioned about this, more and more diagnostic work is done by nurse endoscopists, not even surgeons, not even doctors are involved here. Only nurses will be able to do these things. They are properly trained in doing colonoscopy and upper GI endoscopy. More importantly, no one owns endoscope there. It is the institution property because it is used by the surgeons. There is no conflicting interest. There is no competitive interest between surgeons, physicians, and gastroenterologists because they won't get anything out of it. Their salary is fixed. So there is no competitive interest. So this will help in making
we
the
wish we have
endoscopic
such a
services
open
better.
forum.
Yes, that is
let
better.
me add on to Ram Krishna because I have traveled quite a lot through endoscopy institutes all over the world. In America, as Lakshman put it, still lot many centers where medical gastroenterologists do it. Surgeons are still on a lesser number. Whereas Europe, it is 50-50. Europe, whole of Europe, forget about UK, you mentioned it already. Whereas
Yes,
even rest of the Europe is 50-50. There are certain countries where physicians started dominating now. Whereas when you go to the East, it is a surgeon's domain. It is surgeons who dominate. I have gone to Shanghai where I learned this. I did a course on tunnel endoscopy on POEM and EMR and ESD, where in that the volume of work which is done, there are 30 operating tables simultaneously doing therapeutic endoscopy, totally under the control of surgeons.
yes,
It is
sir.
Department of Surgery who is doing it. And same thing in Hong Kong, the biggest university in the East, China University, Hong Kong, Queen Mary Hospital, it is controlled by surgeons.
Time is
Thank
up.
you,
Ram
thank you,
Krishna,
sir.
please, yeah.
So, because of short of time, I will just like to conclude. So, with this vast discussion, we all agree that there is a need for surgeons to take up endoscopy. We have to extend the endoscopy services across India, especially to rural areas, peripheral areas. So, if surgeons learn, they can do this job very well. Adequate training of the postgraduate students in endoscopy is should be an essential part of the postgraduate training. And training is not really difficult. It should be possible. And credentialing, again, it should be possible. And this job should be taken up by associations like ASI and universities and maybe some established training centers. So to increase the number of training centers across India, where surgeons, if they want to get trained in particular type of endoscopic procedure, this is the need of the hour. And if anybody wants to know more detail about my survey, they can access this article freely through this link. I thank KCSI once again for giving me the opportunity to moderate this panel discussion. I think that was a wonderful discussion. We had a lot of inputs from the panelists. I thank each one of them profusely. And also I thank all the audience and for the valuable inputs and the response, patient listening.
If I may say so, Ramakrishna, excellent moderation. Thank you very much.
Thank you, sir. Thank you.
Yeah, you brought out all the points which are relevant.
Thank you, Dr. Ram
The
Krishna.
doubts in the mind of the people. I think you have brought it out, all of them. Thank you.
Thank you, sir.
Thank you, Dr. Ram Krishna. You need to write the draft guidelines of the outcome of this symposium 2022 kscasicon.
Yes, sir. With the help of
Dr. Lakshman sir and Dr. Siddharth sir.
Yes, sir. Dr. Ramesh will be